Hello, everyone. I think the time is almost 12, so we would like to start our lecture, series of lecture from Professor Edmund Kim. And before starting, I would like to invite all the audience for participation. And if you have any kind of questions or comments in between the lecture, you can just write down at the chat. And after the meeting, we can discuss your questions or comments. And in between the lecture, we will give a link of for the questionnaires. So please participate in that questionnaires, and then we can actually improve our this kind of lecture series in the future. So thank you very much, and I would like to invite Professor Edmund Kim.
Thank you very much, Professor So. And some of you may not know maybe our changes of the title I'm going to talk to you today. I reviewed some of yours comment, and you certainly are interested in listening more clinical topics like thyroid diseases. So I was thinking about to give you lectures on more clinical topics instead of research-oriented topics such as immunology, metabolism, or genetics. So I'm trying to arrange some different topics for your benefit. So today, I'm going to talk to you actually two subjects together. One is parathyroid adenoma. The other one is neuroendocrine tumors. As you know, parathyroid are just around the thyroid. So I will try to give you a talk on the thyroid disease in general for the diagnosis and management, maybe following this presentation or later on, because all these endocrine sort of organs are somewhat related. Parathyroid diseases, particularly hyperparathyroidism, becomes increasing worldwide, and then nuclear medicine department offer specific imaging for the surgeons. So I will talk to you more about why. As you see on this slide, parathyroids are very small, but it's usually behind the superior and inferior poles of the thyroid. Parathyroid produce parathyroid hormone, and that stimulates bone osteoclast. The osteoclast makes an osteolytic process, is destruction, so that there will be increased calcium in the blood. So if we have any patient with hypercalcemia, there's lots of differential diagnosis. One of them is a parathyroid disease. Okay. Parathyroid has a certain cells, and the oxyphil cells, we don't know what's this cells functioning. There are chief cells. These chief cells secrete the parathyroid hormone. Okay. Now here you can see certain homeostasis of the calcium, calcitonin, and parathyroid hormones. As you see here, if you have hypercalcemia, and that will stimulate the calcitonin, and then this all sort of stimulating together, and then if too high, okay, and then the calcium is low, then parathyroid will stimulating and makes the calcium level rising back. So there's kind of a homeostasis or a feedback system in any sort of hormonal organs or systems. Now, as I mentioned, parathyroid hormone makes some significant impact on the bone. It's also class stimulation makes increased serum calcium, and this serum calcium also comes from the liver, as you know, vitamin D. Okay, there's two types of vitamin D, the kidney. So 1 to 5, this is what we usually measure. And this will make the small intestine increase absorption of dietary calcium, so that will also make an increase of calcium. So many the menopausal ladies become sort of sick with a lot of arthritis or bone diseases with less estrogen, I mentioned, and also vitamin D, and then that also relate to parathyroid problems. Here. So again, it's lots organs sort of involved in parathyroid diseases with calcium. So similar things with different things, but keep in mind that the calcium affects the parathyroid hormone, and then that will affect bone disease, and vitamin D is also the. So in clinics, usually measured serum calcium, that should be usually less than 10.3. So anything above 10.5 is hypercalcemia. That's what you. And then we usually measure parathyroid hormone, usually picogram. It's less than usually 50. 50. But we also vitamin D measured this. So certain laboratory has a slightly different normal ranges. So as long as you know normal ranges, then if it's rising, that's always indicating a problem. Okay, sometimes if unexpected high levels of calcium or parathyroid hormone, then you have to repeat and to make sure that's correct. And certainly that's affect also kidneys, so you also check creatinine or GFR, renal function. Okay, so as I mentioned, there are many causes of hypercalcemia. Okay, so chimpanzee, some makes this kind of interesting. Certainly, if you take a calcium supplement, and then hypothyroidism, if you don't move, then the bones are not making things. So this thing, and there's certain medication, MEN, multiple endocrine disease, and parathyroid hyperplasia or adenoma, and the alcohol consumption, and certain panneoplastic syndrome makes a hypercalcemia. So in any cancer patient, you always check calcium. If you have increased calcium level in the serum, you have to make sure that's related to cancer or parathyroid hormone. Joerlinger-Ellison syndrome in GI system, also and excessive vitamin D, excessive vitamin A, and certain granulomatous disease such as sarcoidosis also makes a hypercalcemia. So in cancer patients such as breast cancer, lymphoma, multiple, almost all cancers have a certain hormonal effect or a certain bone osteolytic, and then some kind of there's a vitamin D secretion, and that so those things, whatever the types, they all have a certain, particularly in the squamous cell cancer, has a quite a, often hypercalcemia. A lot of exact mechanism still remains unknown. And then in clinics, we can think about acute or chronic. The symptoms of hypercalcememia. In acute situation, they usually develop sort of nausea, vomiting, and just like any GI disease, and then polyuria, polydipsia, and certainly neuromuscular symptoms like depression, confusion, even coma. And you also check about the cardiac, short QT interval, bradycardia. So hypercalcemia makes a lot of general symptoms you have to check. In chronic, certainly general weakness, hypertension, and some stone, renal stone, carcinosis, and there's certain pancreatitis, etc. So these are the common acute and chronic symptoms of hypercalcemia. Okay, on the EKG, you can see normal QT interval right here, but it's a very shortened interval by hypercalcemia, and certain this kind of arrhythmic condition you have to check, but there are many other differential diagnoses when you see shortened QT interval. So one of them is hyperparathyroidism, we're going to talk about. So in hypercalcemia, you check parathyroid hormone. If parathyroid hormones increase, that's usually hyperparathyroidism. The primary hyperparathyroidism, about 80% adenoma, and the secondary, tertiary all relate to more likely chronic renal diseases. But if you have low parathyroid hormone, and excuse me, you can think about certain neuroendocrine tumor, and then if vitamin D is increased, it's certain lymphoma or idiopathic conditions. So vitamin D, you have to check vitamin D. So in usual management, when you see hypercalcemia in certain lymphoma patient or leukemia patient, you give hydration first, bisphosphonate, calcitonin, and then certain new drugs. So the calcium level here usually greater than 10.5, but about 12 milligram % here. If calcium level is greater than 11, we generally see the adenoma on images. Less than 11, it's very difficult because it's all small lesion. So this calcium level seems to be correlating with our imaging results. Now, if calcium is high and parathyroid hormone is elevated, that's primary. That's this elevated here is a primary hyperparathyroidism. So usually adenoma is about 80%. Hyperplasia, usually 10%. Carcinoma is rare, usually in this hyperparathyroidism. And then if calcium high, but the parathyroid hormone is not elevated, it's called PTH independent hypercalcemia. That's related to excessive dietary intake of calcium or vitamin D, or certain malignancies, as you mentioned. But the calcium is normal or low, but the parathyroid hormone is increased. That's secondary, usually chronic renal disease, vitamin D deficiency, etc. Certainly, when they remove whole parathyroid, and then it's primary hypoparathyroidism, or a certain autoimmune disease can cause T cell kill itself, those parathyroid hormonal cells. That's primary hypothyroidism. So again, we have to think about adenoma first and primary hyperparathyroidism. That's why surgeons want to remove. That's almost cure. Okay, and the but other conditions can also produce. So you have to rule out other multiple endocrine neoplasia or carcinoma or certain medication, including lithium, and the certainly osteolytic malignancy, most commonly multiple myeloma. Okay, certain, as you mentioned, squamous cell cancer, renal cell cancer, certain lymphoma. Those all can cause hypercalcemia, and then some parathyroid hormone may not be elevated. And so this secondary, usually renal, tertiary, also end stage renal. This secondary more related to vitamin D deficiency. So the incidence is somehow ladies have more common problem, and so then the male just like a thyroid, and then it's up and down, but the more and more instances have been reported because of, I think, a routine blood test of calcium in almost every cancer patient. So there's a lot of incidental sort of detection of primary hyperparathyroidism, particularly as you see here, 2% of all menopausal ladies seems to have this problem. And then again, in the primary surgery is the choice. They want to remove adenoma with 80% of the cause of primary hyperparathyroidism. But other, multiple endocrine things, familiar things, you have to always think about it. For secondary excessive vitamin D deficiency, so that's you have to supply. Some in Korea, almost every ladies have vitamin D deficiency, and the that's maybe related to two things somehow. The Koreans don't like drink milk. That's number one. And milk has a very small amount of vitamin D. In United States, milk has enough vitamin D for anyone, and also they like to drink. And also vitamin D, all vitamins are not manufactured in our body. You have to have a sort of external source, or usually dietary intake. But vitamin D is the most important because it has an impact on bone and also immune system. And the vitamin D activated with sun exposure, Without sun exposure, even you take vitamin D by pill or a certain diet, it's not going to work inside the body. But somehow most Koreans don't like to go outside for or beach for sun exposure. That's one of the reason, I believe. But in the United States, everybody wants to go beach and expose themselves so that they certainly develop a lot of melanoma, but they don't have this kind of vitamin D problems, deficiency. The tertiary or this end-stage renal disease, so hyperplasia generally involve four parathyroid glands. So total removal and then transplant, or sometimes subtotal. But usually in this primary, usually only one of four parathyroid involved makes adenoma, and then surgery is usually the cure answer of the problem. And the again, you probably know all this symptoms or mechanism, but as I said earlier, this hypercalcemia or hyperparathyroidism affect all our major organ system, GI system, musculoskeletal, renal system, even neuropsychiatry, cardiovascular. So this hypercalcemia or hyperparathyroidism is increasing worldwide with aging population and also more cancer or some renal failure eventually. So again, clinically, we check this calcium and the parathyroid hormone, or phosphate, vitamin D, to make a differential diagnosis. Okay. Tertiary parathyroidism, end-stage renal, usually a very high level of parathyroid hormone. Primary, secondary, elevated, but slightly. And the calcium primary elevated, but the secondary, the vitamin D is normal or less. Tertiary also increase. But the phosphate is decreasing primary, but increase in end-stage disease. So osteoclast is see this kind of multiple sort of osteolytic lesions. So osteoclastic activity, and that produce calcium. So this diet or sun exposure should activate vitamin, and then here, this activated vitamin D here, this will make calcium absorption increase, and then absorption of calcium from the gut. But if parathyroid gland here, if parathyroid hormone is less, parathyroid hormone also increase renal calcium absorption and phosphate excretion things. So if there's any dysfunctional problem or thing, you expect to see some Again, from endocrine standpoint, this multiple endocrine neoplasia, MEM1, include the parathyroid tumor, and MEM2A include the parathyroid hyperplasia. So keep in mind, when you have a medullary thyroid cancer, you check about parathyroid hyperplasia. That will make MEM2A. Yeah. But if you have parathyroid tumor, then you check pituitary or pancreas to check about MEM1. Medullary pheochromocytoma, neuroma, all things together, MEM2B. So in renal failure, vitamin D is down, phosphate up, calcium 13 down. That stimulates this growth factor, and then bone disease. So this all cycle, and then parathyroid become hyperplastic, and then macronodal hyperplasia become adenoma. So that's you can see in renal disease, if the renal disease is getting worse, phosphate is going up, parathyroid hormone is going up, and the fibroblast growth factor is also going up. On the other hand, the vitamin D is down, and chlorotho genes is down. So this. Okay, so how we handle this problem, and then operation is best, as I mentioned. But if you cannot operate, then certainly medical treatment. And there have been a lot of imaging studies, including nuclear medicine, SPECT-CT, ultrasound, MRI, all things. But MIBI SPECT-CT has been most utilized, at least in MD Anderson. We had a certainly 4D CT, very thin section, high resolution CT, but ultrasound CT shows some nodules in certain location, but it cannot separate from lymph node in cancer patient. It's not easy. But in certain clinical conditions like hypercalcemia, the parathyroid hormone is increased, then it's just a matter of location. So it's useful, but there's high amount of radiation, and then interpretation, etc., makes occasionally, in old days, we did a lot of venous sampling, still do some venous sampling before and after surgery to check about parathyroid hormone, and then certain angio, but those are rare nowadays. Usually venous sampling for parathyroid hormone, since they open up and then they check. So that's the usual. Okay, now parathyroid, as I mentioned earlier, are located around, so posterior to the thyroid, okay? And the thyroid itself is very fragile, and then this very tiny, small organs. So when this become hyperplastic or adenomatous, then become a little bigger, but still very, very small. And there are also ectopic parathyroid. It's rare to above the thyroid, but often mediastinal ectopic. So that's what. Now, there's an important thing that you probably know. Now, many endocrine surgeons go by this Nancy Perriers nomenclature. She and I developed this nomenclature after we have many experience. So surgeons, okay, basically surgeons want to know right side, the left side, okay, and then surgeons want to know superior, inferior. The reason is that if there's an inferior parathyroid adenoma, they usually make a horizontally about 2 centimeter opening, and then they can easily take out this, more likely right behind the right inferior pole of thyroid, which is the most common adenoma, this location. But if we say superior, then they have to have a 5 centimeter vertical resection, vertical. Because in the middle here, recurrent laryngeal nerve runs here. So if they cut, then the patient will have a permanent hoarseness. So in old days of thyroidectomy, they didn't know, they cut the recurrent laryngeal nerve, and also they cut parathyroid, so that many thyroidectomy patients develop, about 20-25% develop such a undesirable side effect, hoarseness, and also hyperparathyroidism, the calcium problem. So they have to take such a calcium hormone things for their lifetime. So that's but now we know, so they are very careful. So the complication is now much less. So you have to provide the information very precisely. In old days, without this kind of things, they usually spend at least 1 hour, but most often 2 hours to find this parathyroid adenoma. So locations. In old days, we say, oh, probably right side, and probably upper or lower. That's not helpful nowadays for surgeons to remove, to find the parathyroid adenoma within a 1 hour period. So we have type A through G, okay? Most common type is type E. That's just right behind the inferior thyroid pole. That's the most common, okay? And then the next common is a superior, but it's a deep. Deep means we call thyroid esophageal groove, very adjacent to esophagus, deep. So deep require, a vertical long 5 centimeter resection. A is superior, but right behind the thyroid capsule, right behind. That's type A, so deep bit. And C is inferior, but deep. So E is EG, we call EG. So C is a deep one. A is superior, but right behind the thyroid capsule. B is superior, but deep. And D is a middle portion. That's a very danger. D is danger because a recurrent laryngeal nerve runs there. So they have to be very, very careful. And then the F is a fallen, the ectopic parathyroid. That's usually in the upper mediastinum. Sometimes it's high, even down to hyla area. And rarely inside the thyroid. There's no way we can separate the thyroid adenoma from parathyroid adenoma on any imaging. They all look like nodular, sort of a low echogenic or low density or high signal intensity on MRI or thing. So these are unfortunately rare. So keep in mind, this is internationally recognized nomenclature of parathyroid adenoma location. It is an old slide, but nothing is perfect. But high resolution ultrasound and usually show 80–85% sensitivity. So CESTA MIBI scan is a little bit better. So putting together is much higher. So all the reports show, depending on how they collected the case, if they have a case of just slightly elevated the calcium, like a 10.5 to 10.6, it's not easy because it's so small, millimeter, 2 millimeter, that kind of size. And 4D CT, show a little bit better. It's a very, because this is a millimeter resolution. So we usually at the end of 0.64 or sort of a millimeter slices, less than 1 millimeter slices, very, very thin section. So that makes a lot of radiation. The 4D, not 3D, 4D. So arterial phase, and then capillary venous phase. It takes time to interpret but relatively a little bit higher, numbers of location. So you combining more study combining far better, but most often in my experience, our CESTA MIBI scan usually identify parathyroid if serum calcium is greater than 11. So this calcium is often positive, negative. It's 11 to me. It's sort of, but the more parathyroid hormone thing certainly makes a more positive finding. The bigger one usually show better, no question about that. So you see this kind of thing, this thyroid, you see a small sort of a hypoechoic node, usually 5–6 millimeter size. Hyperplasia is the multiple nodular sort of enlargement. So hyperplasia versus adenoma on CT, MR, ultrasound look like. Yeah, see, just hypoechoic. So ultrasound always, depending on personal experience, it's thyroid here, uniform echogenicity of tissue, some adenoma or things is hypoechoic. And certainly, Doppler shows some vascularity around particular periphery of the hypoechoic nodule. The carcinoma has a more nodular appearance here, and some echoes inside the tissues. But sometimes necrosis things, calcification makes different features, so it's not easy. Now here, this is the thyroid, okay, but with contrast, jugular, carotid, arterial phase, and this is a inferior pole right behind here, the nodular enhanced. Without contrast, thyroid is slightly dense because of iodine, but it's not easy to recognize nodule here. So 0–30 seconds, this second you see here, and then venous face is a little bit washing out. So it's not easy. So in old days, we use pathogenesis failure. This is the old days. Sesame, but sesame uptake in tumor is also variable, but the principle is related to cellular membrane potential. If any cells are growing excessively, there is a membrane potential difference outside, inside the cells. That's electrical difference. That's the sesame. And that in and out is controlled by P glycoprotein. So that's just a principle, but just like everything else, it's hard to explain just based on one principle, because there's so many exceptional cases or variables. So using this mechanism, maybe we use about enough dose, 20-25 mercury, and a certain low energy parathyroid column at high resolution. And then without SPEC, as I said many times, it's overlying soft tissues, all things. Unless the tumor become bigger, you cannot detect a tiny one. So you need the spexity to locate properly, because of that international nomenclature require some relationship between esophagus and also is superior, inferior things clearly. So spexity is the best. And then this is also a membrane potential difference on this diagram. So P glycoprotein apparently influence this mechanism. Again, same thing, P glycoprotein in and out things. And obviously this goes in and to the also this mitochondria, energy factory things, and you can see box, BCL, bed. These are all genes affecting of these things, just like any other. See here, this all quite an old slide, but still, still can be used to point out. So using sesame, you can see parotid gland, submandibular, sublingual is in the middle. It's so small, maybe you don't see it. The thyroid, just like a pathogenate, it's not trapping things. It's just uptake, maybe a normal tissue in immediate, right? For injection. You can see some certainly blood pool effect. So after 2 hours, usually it's washed out. This gland contain activity quite long, but thyroid takes up and washed out. But you can see a little bit here on this planar imagings remaining. Okay, remaining. And this could be E type or could be C type. E is right behind the thyroid, or C is a little deeper. You cannot call CE based on this planar imagings. You need leather view at least, or some spexity is the only way. So this is a usual behavior of sesame. So in another case, okay, you can see some area, particularly in this most common place, right side, inferior, easy, right behind the port, that's E type. That's but E or C on planar, you cannot evaluate the depth. Okay, yeah, and this is another one. Okay. And on this, just spec, you can fairly locate it here, left inferior, okay? But still, on this axia, you can see it here, looks like this esophagus is someplace here. So it's quite a deep, so more likely C instead of E. But it's a scattering artifact or things makes it difficult to say clearly. Okay, so in old days, sesame may be subtracted by this iodine trap organifi subtract, and then this left. So it's here suspicious, but not clear. But with the subtraction of technetium, sodium pertechnetate, or iodine 123 sodium iodide, it makes it easier to clear. And this maybe another one. Okay, so again, we are subtracting and makes this kind of thing. And on the lateral view, you can see quite a deep, but you know, by rotation a little bit, it's not easy. Okay, here's some more technetium subtraction you can see here. So in old days, the CT was not good CT, but at least on this color, right behind the right inferior thyroid pole right here. The esophagus is right here. If this one comes a little bit further back or near here, that's a C type. This is more like an E type. So that requires just 2 centimeters transverse resection of the skin. So here, something like a thyroid isthmus, but oblique. And so if you don't have, you can take out this, one view is least reliable. You have to make sure oblique lateral or whatever thing, but SPEC is the best. So this is deep, it's deep. It's whatever body esophagus right here, bad. This right adjacent to the, so right here. That's a C type. Okay, another one here, right in front of whatever body. So that's a deep. This place is called thyroid esophageal groove space. Okay, and this one is here. This thyroid. This right behind here, right behind. So that's a E type, most common type E. And then some are multiple adenoma, or some maybe hyperplasia. But the large one is right, most functional, active. Usually in this kind of cases relate to a tertiary, or sometimes a secondary rather than primary. Multiple, some is adenoma, other maybe hyperplastic. So hyperplastic, macronodular hyperplasia become adenoma. So some more case, in this case, right in the middle portion. And that's we call dangerous because recurrent, you see this is thyroid right in the middle, recurrent laryngeal nerve goes right there. Yeah. So when they resect this kind of case, require a lot of special microscopic microsurgery and try to avoid cutting nerve. Okay, some fall down into superior mediastinum. That's called F, right here. In this case, endocrine surgery or general surgeon ask a thoracic surgeon to join and open up superior mediastinum. So, and on this, see way down here, so it's the right, it's anterior mediastinum focal antennas. So again, this kind of things, or this F type. So sometimes way down to pericardium. See, that's crazy things, but you can see it. So in this case, cardiothoracic surgeon involved and take out this, and then cured. Now, certainly choline has been used to evaluate prostate cancer, other soft tissue. So choline is sort of a fatty acid metabolic process. So any cancer can show some increased uptake of choline. And then you can see also very focal intense increased activity here. That's right behind the right side, so E type. So using choline, it shows also. But any amino acid may show also. So this is another F anterior mediastinum here, right here, small nodule, show very. Okay, so you have to educate your maybe endocrine or general surgeons that you can help them in locating parathyroid adenoma precisely in short time with this specificity using CESTA MIBI or any amino acid or tumor sort of radiopharmaceutical, and then show some of this kind of cases, and then they will test you. But you evaluate the patient based on calcium. If calcium is borderline or parathyroid hormone is borderline, then your chance for detection is sort of mediocre, very questionable. But at least 11 above calcium, and then parathyroid hormone 250 above, that's easy. That's easy. So hopefully you can help your surgeon and ultimately patient with this imaging guided management. So we'll take about 10-15 minute break, and then I will talk to you about another endocrine tumor, neuroendocrine tumor, which is now probably very important in nuclear medicine because we are using theranostic agent for diagnosis and therapy. So you can write down any comment or question or any suggestion on your sheet, whatever, so we can evaluate your some wishes. So we'll improve continuous lectures in the future. So let's take a 10-15 minute break. I have 12, your time, I don't know, but just go to either take some water or restroom, whatever, and then come back in 15 minutes. And we'll start with neuroendocrine tumor. All right, I hope you are ready to continue listening my talk. Since I have quite a slides, I like to start now. As you know, that neuroendocrine tumors become also quite a exciting and also maybe familiar with the many clinicians because it becomes increasing worldwide. we didn't recognize small cell tumors in almost every organ previously. So neuroendocrine tumor receive some signals from nervous system and makes a certain hormones. That hormone control our bodies, but particularly digestion and breathing. Okay, so there are functional tumors which makes a significant amount of hormone and cause some symptoms, but there are non-functioning tumors that certainly cannot make any clinical symptoms. Generally, neuroendocrine tumors are slow-growing tumors. However, but some tumors are slowly growing, but at some point it grows very fast. But almost all neuroendocrine tumors are small cell type. So from the beginning, it infiltrates all body system. But it's slow growing, but at some point, so it never cured. And almost every case I have seen eventually metastasize to the liver. So it's a multiple organ environment and multicentric. Therefore, surgery is not curing tumor. Surgeons usually operate to avoid any intestinal obstruction or certain compression symptoms or signs. But this has to be treated with systemic therapy by either chemo, endocrine, and now radio immuno or radio protein agents. Okay, it's increasing continuously. Okay, as you see here, most commonly we call carcinoid. That's increasing in the small bowel, but or other types, lung, other types also all increasing. And then, as I mentioned, once they advanced and then aggressive, it's hard to control. And we can only slow down if we diagnose early and make adequate treatment. So we now have a certain peptide, like octreotide or dotatate, and then we put the radionuclide, and for the diagnosis, like indium, and then gallium-68 for PET, this is PET. But now we have lutetium-177 or rhenium-188 for diagnosis and therapy. Now, these neuroendocrine tumors secrete somatostatin receptors. There are at least 5 or maybe more receptors. But our scan agent usually attached to somatostatin receptor either 5 or 2. 5 is more abundant in many cancers. All right, sorry for the technical problem. And as I mentioned, this neuroendocrine tumors are small round cell tumors, small. So almost any tumor now has this small cell type. So it's a differentiation markers like CD, all this 99, 45, all kind of things that have been recognized. I have to move a little bit fast. So it's a nomenclature by WHO has been listed as you see here, and traditionally carcinoid things, and then now just the neuroendocrine tumor, you know, and a certain location. The grade, histological grade, is classified low to high, and this determined by pathologists based on mitotic numbers. Less than 2 out of 10 high power field, and no necrosis low, but greater than 10 mitosis is high. So this grade is related to prognosis. And certain KI in the 67 index certainly correlating with this one, this proliferation marker. So like every other cancer, no one knows exactly what's the cause, but we know certain multiple endocrine neoplasia and neurofibromatosis type 1, and this gene from Hipper-Lindau syndrome gene contribute this neuroendocrine tumors. Okay, so it's almost every organ you name has a lot of genes, associated genes here. You can see many genes, and these genes. We now have a sort of a targeted therapy based on just gene things. So just like every other cancer, there are many influencing genes in the pathways to make a tumor cellular proliferation and eventually metastasis. Okay. And so now we have many specific genes like targeting tyrosine kinase, mTOR inhibitor, everolimus, these things. And then, so these kind of new therapies. And certainly still, we have to suppress growth by somatostatin analogs. Sandostatin is common commercial name. Okay, since we don't have much time, I think this kind of usually signaling pathways are more like in research field now. So many you can see. It's complicated. That's why tumors are not easy to control, and there is a tremendous individual variation, or even in the same patient, they have a continuous biological evolution every day. Okay. Now, primary versus metastasis has also different sort of phenotype and then genotype as well. So about 20-25% small cell here. And still small intestine carcinoid with ileum, that's most common, but other pancreas, other all organs also involved by small cell neuroendocrine tumors. So now we call carcinoid syndrome. That's in the ileum, and the tumors release serotonin, and they produce in the intestine, but it works in the brain. So that's why now sort of a lot of research workers are studying a microbiome to associate with the many diseases. And the well differentiated is a slow growing, but somehow at a certain point that become poorly differentiated. Just like a thyroid well differentiated cancer become dedifferentiated and poorly differentiated. That's by a lot of gene factors and stress, many other things make mutations of all kind of genes. And the you can see this gastrinoma, insulinoma, glucagonoma, somatostatinoma, they're producing certain hormone they named things. Yeah. So it's grading here based on mitotic amount, and then a certain this proliferation marker is all correlating, and the functioning versus non-functioning, but the 80% express somatostatin receptor, usually most commonly 5 and 2. So there are certain specific centers in the United States, at least they are specializing sort of treatment things. And they recommend a certain CT, MRI to follow up. As I mentioned earlier, usually when we initially diagnose by MRI, CT, and then certainly if there's a tumor in the ileum, small bowel, we recommend surgery to avoid any intestinal obstruction, and histological diagnosis obtained. And then you have to have a workup of whole body system, because it's a systemic disease, and particularly tiny nodules all in the liver, many things. So using CT, MR, ultrasound, and FDG PET scan, and then more specific somatostatin receptor imaging. Poorly differentiated obviously takes a lot more FDG, but well differentiated show uptake just a little bit, not much, because there's not much active glucose metabolic process. But high grade certainly show. Somatostatin receptor imaging is certainly more specific. But again, in the same patient, some lesions may have a receptor 5, then it will show. But if the lesion has a receptor 2, you're not gonna show. So what? When you see multiple lesions, we usually put the sandostatin suppressed. If some lesions on follow-up show response, that's good, just keep on. But if many lesions, particularly big ones, are not responding with the sandostatin on the images, then usually surgery is required. So our imaging guide certain specific management. It's all receptor, lung, and the all other, parathyroid cancer, medullary, thymy, paraganglioma, pituitary. These are all small cell neuroendocrine tumors. And particularly pheochromocytoma, the adrenal medulla would have chromaffin granules. The paraganglioma is extra sort of adrenal, same tumor. So in the old days, we call precursor of pheochromocytoma, but the outside just adrenal, but the same pathology. So we use MIBG to diagnose and treat pheochromocytoma or paraganglioma. So there are many tumors expressing somatostatin receptor 2 or 5. I already mentioned, most commonly pheochromocyte paraganglioma, neuroblastoma, and certain gastrointestinal carcinoma, gastroma, insulinoma, etc. And thyroid medullary, and certain Merkel cell skin cancer, and small cell lung cancer. But you also know that certain tumors have a low expression of receptor 2 or 5. They express more somatostatin 3 or 1, then our current imaging may not show this kind of thing. So it's breast, lymphoma, prostate, but even prostate, well differentiated receptor maybe little bit, but when they become poorly different, then expression of receptor 2 or 5 become a lot more. So it's changing, but this is general things, okay? So there are certain tumors without expressing things, certain inflammatory lesion, infection, etc. So depending on what they produce, mainly hormone in certain organs, they named this kind of tumors. Duodenum things, gastrin produce gastrinoma. In pancreas, insulin, glucagon, vegetative peptides, so that's called insulinoma, glucagonoma, vegetative tumor. So pancreas somatostatin produce somatostatinoma. Calcitonin, that's a medullary side. Norepinephrine, yeah, there's norepinephrine that causes increased blood pressure. So clinical symptoms, signs, you can imagine, or diarrhea, abdominal pain. And so systemic syllabus is influenced by the tumors. So all kind of things you can expect. We use chromogranin A mostly in clinics in the well differentiated, grade 1 or 2. When this the tumor becomes aggressive, this chromogranin A may not be elevated. So this early disease, early maybe earlier things is useful. But when this becomes increasing, yeah, certainly. So other factors also influence. So nothing is completely reliable. So you have to consider gastritis, kidney disease, liver disease, etc. And certainly certain diet, medication, a lot of medication things. Some medications elevated, some decreased. And we usually obtain 5-HIAA, hydroxyindole acetic acid clinics when you suspect carcinoid. So chromogranin A, 99% carcinoid, small bowel. Certainly 5-HIAA we routinely check. But recently we check also neuron-specific analyze, so neuroendocrine tumor. And in the gene assay profile P30A also check. So somatostatin chemistry like this. So the octreotide is just a 10 amino acid here. And within this one, we put the indium and chelation. So that's the indium octreotide here. So iodine attached to here, amino acid, so octreotide. And the, as you know, indium, and iodine 1, 2, 3, a good agent for imaging by good physical properties, optimal sort of half-life, But these are all produced by cyclotron, so it's quite expensive. That's a limitation. But if you don't have a PET camera, then this is the choice. And at least you have to have a SPECT CT. Any tumor imaging require hybrid imaging system because SPECT CT or MRI things make a precise localization and then characterization of the abnormality based on morphological CT or MRI. And then you may have additional information from CT, MRI, detection of tiny 1-2 millimeter size metastases, etc. So somatostatin receptor 1 to 5 thing is all receptors working with all this calcium, some genes inside the cells. So when anyone produces a symptom, you have also biochemical tissue diagnosis, and then the imaging, and then the surgery initial. Usually, GI tumors require surgery because it'll grow and obstructing intestine tract, and then a certain octreotide suppression, and then some immune interferon, gamma interferon. Certainly, if there is a certain liver things, embolization to give to shut down the tumor blood flow, and certain angiogenesis inhibitors to get, and then lots of new chemotherapy. So again, staging is not, it doesn't mean much things, but sometimes very small earlier, well-differentiated tumors can be resected by endoscopy, but mostly surgery followed by additional certain therapies. But this is a multicentric systemic disease. So liver metastasis is a major clinical concern in my experience. And depending on the location of the neuroendocrine tumor, they have certain slightly different approaches, but basically the same. And the peptide sort of radionuclide therapy has been studied mainly in the Europe for last decade and become quite a successful, particularly a certain resistant suppression or chemotherapy patient. Now this is some old slide, but still show subcutaneous tissues. You can demonstrate this one. And octreotide, some show always relatively greater intensity in the spleen and the kidneys, obviously. So there's some somatostatin receptors in the spleen, so very intense. When you have an intense spleen, you can think about labeled white cell, blood cell, red cell, or platelet, and plus this octreotide sort of somatostatin receptor imaging. And the leukocyte should not show, red cell should not show this kind of intense kidney activity. Only somatostatin receptor imaging show here. So when you see hot spleen, hot kidney, that's a somatostatin receptor imaging. And you notice there's no other except for bladder, nothing. So these are all. And you can see multiple focal areas of slightly to moderate increased activity. The intensity seems to be related to the amount of the hormone secretion, and the always, lots tiny lesions, multiple lesions in the liver. In plana, you may not see, but SPEC or PET usually show tiny multiple lesions. Okay, so here's retroperitoneal area here, or here in the abdomen, gut, all the things. So sometimes in the bone. So it's all, they involve every organs. So this is the indium octreotide studies. FTG show, but some intensity is a little bit in very different. But if this become a higher grade or fully different, then you see intense activity. Now, this according to literature, detection is about any test greater than 75 to 80% clinically useful. So it's all neuroendocrine tumors show this kind of, but some you can see a little bit less. Again, there's quite a variability depending on the grades, the proliferation, and also amount of receptors, Even in the same patient, some lesions are very high, some lesions are very little. Those are all depending on several factors, as I mentioned. Different receptors, amount, vascularity, etc. Yeah. It's not the same, yeah. But just like any other radiopharmaceutical study, there are false positive. Any area with increased blood flow takes up by blood flow phenomena, so inflammatory lesions. Because of intense activity in the spleen by receptor, you may detect easily accessory spleen, just like a technetium red cell, and certain scar tissue, the fibrous tissue. Earlier fibroblast has quite a vascularity, that's why it's so. But later chronic, you're not gonna see it. Sometimes it's metabolized in the liver and then show gallbladder, certain thyroid goiter, and other things, certain intestinal and certain tract things, and nasal uptake, and patient with common cold, certain inflammatory reaction, I suppose. And the vascular, stroke, and the diffuse breast uptake. This must be related to hormone, hormone. Normally, there is a little bit in bilateral adrenal normally, but urine contamination certainly expected, and so negative, obviously certain receptor 1 or 3, 5, 3 or something, and then certain different sort of tumor with less receptor. And then a small tumor you may not see. And then so variable tumor differentiation makes such findings. So all the slides but show all the lesions in the mediastinum or abdomen. And the this little bit here, the pancreas, but on the side, this proximal body of pancreas, you can see. So spexity locate. It's very old slide, but they show easily on spexity, carcinoid, the small bowel, and the lesion, lung, here. Okay, this so-called giant cell neuroendocrine tumor here. They're almost like a pneumonic infiltration. And then sort of left side hyla tumor. This is all proven case. That's a neuroendocrine carcinoma. Show. So FTG also show very intense in this kind of. And obviously pancreas lesion show. And obviously this is a AP window lymphatic chain here, very focal intense. In addition to left maybe submandibular area or left cervical lymph node metastasis. So many multiple nodes. This is the usual findings of many cases. Because of slow growing, some bones are osteoblastic things. Okay, we see something. So here something before after suppression of neuroendocrine function, neuroendocrine tumor. With somatostatin analog, maybe in the mediastinum here, yes, it's not so clear. Okay, there's a bone environment here. This is called iliac tuberosity. On posterior, you may see asymmetry. The iliac tuberosity is up way back, so anterior doesn't show, but this one. So on planar, you may suspect something here better, but obviously you require SPEC to correlate here. So this diagnostic accuracy by indium SPEC octreotide about 70 around, but there's quite a variation. Some 49, some high, depending on, again, amount of different kinds of receptor, amount and functioning, etc. And the MIBG, it goes to chromatin granules. So depending on how much granules, the pheochromocytoma, paraganglioma are supposed to be high. So that's, and dopamine, yeah, dopa is also produced half in liver, half in intestine, something, and then show wide range, in pheochromocytoma, although numbers are small, 100%, paraganglioma 100%. So dopamine has been used in brain tumor, other, cancers. Maybe this neuroendocrine also is useful. FTG, again, only medullary or very aggressive tumor. The slow growing tumor doesn't show much. So it's multiple hepatic and then bone. It's a very expansive lesion here. Oh, this is a whole body PET MRI. This is a DOTA TOC. Now there's DOTA Tate seems to be, but multiple lesions, tiny lesions, this kind of things. MR should show tiny lesions, but it's non-specific. You can't tell whether this is a tumor, like a leukemia, other things, or red cell hyperplasia. When the patient becomes anemic, bone marrow try to make more cells, so the red cell become hyperplastic, and that cause just like this, just like on T1, it shows the rounded spots. So it's not easy, not specific. And you can see very intense, multiple filling all the liver here. And so it's DOTA-TOC, pancreatic tumor metastasized, very intense functionally. And another case is also here. And certainly you can see maybe in the bone, you can see here. Well, in the thyroid bed, you can see tumors. Yeah. I can see also tumors, but it's a multiple systemic, and there is a sort of increase signal intensity of T 1, 2, 3, 4, 5 here. And you see just a little bitty increased activity on DOTA-TOC, and this was not a neuroendocrine tumor. This was turned out to hemangioma on T5. The hemangioma is a vascular pool. So it shows on T2 high, and many series of false seropositive case. Pancreatic, again, is a multiple liver or this other area here on transaxial, even acetabulum here. Okay, pancreatic here, nodular here, increased activity here, and some retroperitoneal. So this DOTA-TATE is now seems to be choice compared with other, arterial scan, MIBI, MRI. This seems to be better in detection of multiple lesions, and the so they hook this DOTA. DOTA is chelation, octreotide, gallium, and then hit the somatostatin receptor 2 or 5. And then the comparison here, but primarily gallium has a higher resolution, show run more. Now, if you have a new SPECT camera, using cadmium zinc telluride, you may have the same thing or even better. But comparison with the planar versus tomography PET is not reasonable on the paper here. Okay, so this DOTA-TATE, you can see again, very increased activity in the spleen and kidneys. So those are, but normally you see some little bit active cells in the thyroid and some intestinal tract and urinary tract as well. So normal organs distribution. So in the literature, initial staging, localization, and some selection of patient for the peptide receptor radionuclide therapy, RRT, or prior surgery for the staging, and for the biopsy, or monitoring recurrent or metastasis progression. And then certain cases with the negative conventional imaging, but the biochemical markers are questioning things, and you need the scan. So in intermediate or indeterminate lesion on conventional imaging, you need this kind of more specific. And it's usually we give around 5 millicurie, and then have a scan at 1 hour following injection and show. again, a low grade, well differentiated versus high grade by looking Ki67 index, and you expect the positivity much higher or less. Things. This is more in Galley PET scan the other way around. The scan is a little bit, but very intense on poorly differentiated. So, and false negative, certainly very small size, or this, sort of a, they call it flip-flop. Low uptake FTG, then you have a high dot somatostatin receptor imaging, vice versa, as I just mentioned, FTG. So by utilizing two agents, you can assess biological status of neuroendocrine tumor things. Okay, here the examples. This dotatate after the somatostatin imaging show lots of lesions in the liver, but nothing much here on FTG. That means this tumor is well differentiated. And proliferation index less than 1%. The other way, you can see FTG lots. It's a flip-flop, yeah. That's a typical classical examples of biological imaging, functional imaging. So some makes scores or things on the dotatate imaging. Based on the liver activity or spreading activity, is certainly greater than spreading activity. It's a high score. Very low, less liver is very low. So you can say it's almost same intensity as spleen. So it's a great score, maybe 4. Yeah, lesions here, very intense. It's very intense. And the pancreatic unsnate maybe process. Okay, again, false positive, normal prominent pancreatic unsnate process has some activity, but not as standard like that. So this is some increase, but that's why the PET CT or PET MRI is helpful to locate the unsnate process. Splenosis is the same thing. A lot of inflammation, inflammatory reaction, which shows the macrophage leukocyte, also show very high receptor. So you can imagine false positive, arthritic fracture, surgical wound, radiation, pneumonia, abscess, pancreatitis, granulomatous disease, sarcoid, such. Also, blastic activity. A certain growing sort of epiphysis in children, degenerative changes, certain pages, fibrous tissue, or some hemangioma show some uptake that's false positive, but intensity is different. So it's a variable uptake depending on the amount of receptor or types of receptor. And then high expression usually in common, we can say field, paraganglioma, neuroblastoma, those are common indicative tumors in our clinical practice. And then medullary, pituitary, small cell lung, meningioma. But others show some, but when they become dedifferentiated or undifferentiated shows, so this kind of pancreas unsnate. And the meningioma shows some meningioma. So it's focal increased activity, just like FTG. But this could be adenoma, could be cancer. But if you see it like this, yeah, that's a cancer, metastasis to the right? Hilar, infrahilar together. So thymoma anterior mesenchymal is vague here. It's uptake, but not much. Here very intense, and then here some this diffuse lactating breast. Any radionuclide will show similar, but it's a very focal intense breast. So this benign prostatic hypertrophy also, prostatitis, cancer, all show. You have to correlating with the clinical laboratory, other things. As I mentioned, hemangioma, some blood pool, even enchondroma show some uptake. Some even osteomalacia non-specifically show. So here, carcinoid metastasis. So now rotation, 177. So rotation has about 200 kV gamma ray. That will make a picture. So medium energy, if you have medium energy collimator, it will show nicely. But the rotation 177 has also 500 kV beta ray that will make a treatment. So if you get low dose, it will make a gamma imaging. If you give large dose, that's a treatment. Internal radiation therapy things, specific radiation. So that's become approved by Europe, and I think in United States also approved. So it's going to be just started. Like a multi-centric things here. If these are not suppressible by sandostatin, this is the choice. So certainly you can make a picture, but currently dotatate has the highest resolution, detailed things. Then you give it this rotation 177 high dose. So now, see, pheochromocytoma is called syndrome. It has a multiple gene. It's depending on gene, what kind of tumor, medullary, a lot of multiple endocrine tumors, syndromes, so paraganglioma, as I said earlier, extra-adrenal neuroendocrine tumor, there's paraganglioma. It's common genes, SDHX, this gene. Usually head and neck is most popular, most common paraganglioma. And certainly the pheochromocytoma is around the adrenal, abdomen, intestine, things like that. So usually gene profile show this kind of SDH. VHH is another common, and NF1. So you have to check if these are all recognized, then you have to check other renal cell, pancreas, hemangioblastoma, in addition to pheochromocytoma. Yes. So it's a recent order recommendation. Shows some grading, cellularity, all this by pathologists and correlating with the proliferation index. And then certain urine metanephrine, normetanephrine measured, but basically, most often 24-hour urine categoramine. And then you have abdominal CT, MR, and certain genetic studies. And then we still use FTG PET, but as I mentioned, this will show only polydifferential anaplastic or dedifferential tumor. If it's well differentiated, you're not gonna expect to see much uptake. So more neuroendocrine receptor imaging will be better, like MIBG or dotatate. So basically, we usually start with alpha blocker, followed by beta blockade to control cardiac rhythm or combination. And then resectable case is the surgery. But unresectable, we usually have this imaging, MIBG, and then this peptide therapy using rotation dotatate nowadays. Distance metastasis, certain, if the lesion may obstructing certain organs, then you need a certain reductions, surgery, but basically various chemotherapy, including temozolomide, and some this peptide radionuclide therapy. So for imaging, we use various agents like this. FTG, as you know, is related to glucose transporter 1, hexokinase 2, and pH or some certain enzyme or things or influence. Dopamine sort of amount influence beside the amino acid transport. It has to be transported, and then just like any other receptor imaging, specifically to receptor 2 or 5. And the MIBG is related to chromogranules, which produce norepinephrine. So these are more specific, but depending on how much receptor, what kind of receptor, makes a difference in the imaging finding. So all here, depending on what kind of gene they analyze, and they recommend a certain specific agent here. And but for considering radionuclide targeted therapy, you have basically a choice of either one sort of MIBG or a peptide. So usually dotatate using lutetium-177. But these agents show different sort of results depending on these genes. So again, same thing. Sometimes this somatostatin receptor is better on certain gene mutation. It's like this. This gene showed tremendous metastasis. Yeah, sporadic metastasis. And dopamine also show in certain genes. And again, this is a common paraganglioma genes. It shows lots of things. But red paraganglioma also shows some. But by dopamine and FTG, but in clinical practice, we don't have this kind of super selection. If we believe tumor is more aggressive, FTG, if early diagnosis, more specific things, MIBG or dotatate. Yeah, like this. That's now 2, 3 MIBG specs. They show very nice, or like this. So for diagnosis, multicentric or things. And the this is again cyclotron producing expensive ones. So we use a small dose to save money, and that's sometimes a small lesion miss. And certainly FTG sometimes shows a very aggressive tumor metastasis. It's this gene positive. And then some compared things of paraganglioma. It's unusual to have this kind of intense with FTG in most paraganglioma initially, but this well-differentiated become anaplastic, de-differentiated, then you expect this kind of things. And the more specific MIBG was Dr. Tate show some, but this already probably, these are better with well-differentiated cancer. So metastatic paraganglioma, you can see tremendous. It's metastasis. This from here, it shows a large lesion, but it doesn't show much intense uptake. Again, the intensity is related to receptor type and amount of receptor. And so this is a focal lesion, very focal, but very intense. Yeah. And multiple lesion in the liver, very, very much so, this kind of things. And here, paraganglioma around the neck, carotid body area, that's the most common size, is large mass in the carotid space. This is a nasopharyngeal right side space, so intense here. And again, left side, this sort of a petrous rich bone, this bone lesion, like a meningioma type. But this is a metastatic pheochromocytoma. So the DOPA is also show very high sensitivity and specificity because this mutation here, and then much better than MIBG. Okay, and the neuroblastoma in stage 3 or 4 shows very high. Yeah. So L-DOPA is another popular tumor agent. Yeah, but at this time, Dr. Tog or Dr. Tate usually used because higher sensitivity than iodine 123 MIBG. Or even in this case, sort of paraganglioma is higher than DOPA. So Dr. Tate. But again, this kind of things, it's all related to, sort of biological status of the tumor. It's quite a variable in my experience, so I can make this kind of conclusion. So after initial surgery, we check certainly blood pressure. That's no epinephrine effect. That's okay, and so always check blood pressure things, and then for the surveillance, chest CT and abdominal CT or MRI or FDG PET CT all together. And then this is from strong Catholic new agent. It's similar to MIBG, benzoguanidine differently, and then shows some lesions in the liver things. And this also from publication. This is a leucine derivative, just like we are using same agent for prostate cancer. This also amino acid is not cooperating in protein synthesis, but this is a synthetic leucine derivative transport to tumor and transporter, and then phosphorylated, and then stop, no more further metabolic process, stop. So we are looking phosphorylated leucine, and in sort of trial, clinical trial thing, they all show some neurofibril tangles. They just like Alzheimer's type disease, and then make some kind of scores. And neuroblastoma is a pediatric tumor, and then it's involved the bone marrow things, and then certainly multiple organ involvement. And the stem cells has been used to make a little better survival things. And then the MIBI scan is still used, but the scan is not easy to pick up certain small marrow lesion. It's a diffuse pattern. So if you have a certain increased activity scattering in the marrow, often the spine and the long bone or pelvic bone, you follow up. Recently, there's a report of NK cell therapy for neuroendocrine tumors. Okay, so NK cell is a relatively small amount of immune cell. So there is a new technique to expand, to increase the amount of NK cell ex vivo. So that's why there are many trials to treat tumors, leukemia, and then solid tumors nowadays with NK cells. Using T cell, there's a lot of graft versus host, certain complications, but NK cell has much less certain. So they use a lot of these trials to see any response. And there's a lot of complicated mechanistic things using multiple factors. And so for surgery initial, and then somatostatin receptor specific diagnosis and the therapy. And if that failed, the chemotherapy, commonly temozolomide and cyclophosphamide, vincristine, that's how used. And then certain localized certain bone or certain organ environment, external beam radiation often used. And they all show some tyrosine kinase mutation. So sunitinib, popular tyrosine kinase inhibitor. There's a multiple types, but this is a more sort of a general type things, and they use this one and help for some patients, not all patients. So it's a rapid growth case and slow growth case. So we want to find out what makes this kind of different types. Certainly genes, all things play a role. And the rapid growth chemotherapy usually applied, but slow growing and thing, and it's internal radionuclide therapy have been successful. So in this MIBG therapy, slow growing, progressive, symptomatic, at least positive MIBG scan, and then it's compared to chemo, relatively less side effects, particularly hematopoietic side effect. And you can see some response on the images. And this rotation therapy here is quite a dramatic. Multi-center here, It's almost gone, so that's good. Yeah. So these are fairly well differentiated type. That's why it's responding. And the survival is much different, helpful. So there's a lot of publicity and publications all show here. And then instead of beta ray, actinium certainly is alpha seems to hit the tumor better when they're small. If tumor become big mass, you are hitting only surface, that's not going to be successful. But in the tiny multicenter thing, this kind of radionuclide, internal radiation therapy, particularly using alpha ray, makes sense. And pre-medication, we usually certain suppression first, just like a thyroid storm we may see when you hit the tumor so much, there's some hormones release and makes a clinical some stormy symptoms or signs, so always prepare. So toxicity, every therapy has toxicity, just a little bit, much less compared to chemotherapy, particularly on hematological complications. There's some renal, but manageable. And monitoring after this therapy, that's a sort of hormonal crisis. We always think about it. Okay, that affects the skin, intestine, heart, respiratory system. And so this is a scan again. This is a technetium. This using high nickelation show same tumor, but when there is a large necrosis, you are seeing only active cells, cancer cells surround. That's technetium. And there's a survivor using peptide a little bit better here, but then also here paraganglioma, this using peptide compared to MIBI therapy, survivor is better. And but again, depending on the collection of patient, this is limited to patient with somatostatin receptor 2 or 5. But this MIBG is as long as the tumor has a chromatin granule, it goes their head. So actually, this will be more universal agent, but depending on what patient collection and the staging of disease, this number so will be variable. So during coronavirus things, how you treat, some literature show that's kind of scan show lesions here, and then okay, I try to move fast. So I think you have a good concept of parathyroid adenoma as well as neuroendocrine tumors. Those are all hormonal sort of tumors. So you have to work with your endocrinologist and certainly oncologist. You can introduce, educate them our ability to demonstrate and also treat patient if they failed, or ideally if we can combine internal radionuclide therapy plus conventional certain suppression or chemotherapy, etc. So I'll stop here And then if you have any question, you can write down things, or you can email me, or certain our routine survey paper show a lot of good comment. I read yesterday. Don't hesitate to write down whatever you like to have a benefit, and we'll try to make your wishes to be true. Okay, have a nice day, good day, and then I'll see you next week. Thank you. Thank you very much. Question now, we still have about 10 minutes. Can you hear me well? Okay. Thank you.